This is a Founding Media podcast.
Hey guys, welcome to Apple a Day Doc Talk. I'm your host, Dr. Ramdeen, and I have Eric Finger here again from Physical Therapy. Hey, Eric.
Hey, how's it going?
Hey, he's here as part of a 3-part series. So we were talking about upper cross syndrome, lower cross syndrome, and today we're going to talk a little bit about ankle distortion syndrome. First, I want to introduce Eric. Eric is a mobile physical therapist, so he's here in the Austin area. He'll come to your house. He'll go to your business. He'll go wherever you are.
Yep.
Right?
Exactly,
And he is a Midwesterner, began his formal education at the University of Kansas, and he was on the varsity swim team, right?
Yep.
And so got your Bachelor of Science there in exercise science, and then completed your graduate training at Texas Tech University Health Sciences Center in 2002. He then graduated and had a very impressive postgraduate continuing education regimen, becoming an APTA, board certified orthopedic specialist, and a fellow of the American Academy of Orthopedic Manual Physical Therapy. And this is a distinction that less than 10% of physical therapists have in the United States. So tell me a little bit about that, Eric, and why you got that certification.
Yeah. So, after, getting out of school and such, I kind of had this, I need something. I need to, go back and do a little training and such. So, in the physical therapy world, going board certification is the kind of the next step. Looking at your competency and such, and it was a great way to kind of refresh on things, learn other things, and it really helped with my practice. And I went into a manual therapy fellowship, which was great, working with some of the top therapists here in the country and here locally too. They were the lead faculty and such. So manual therapy really allowed me to, learn techniques from just, be more better at diagnosis and looking, and analyzing movement, and also just treating joints and muscles much better.
Some soft tissue work that you talked about doing, right?
Exactly, yeah. Soft tissue work, joint mobilizations, and just really analysis too. I think really having a keen eye at doing what PTs do. We kind of analyze movement all day. I catch myself even just when I'm walking around. Ooh, look at that.
And one of the reasons why I like working with Eric and we take care of mutual patients, because he's also very into fitness, so understands this population very well. He likes to compete in triathlons, escape from Alcatraz, Ironman 70.3, right?
Yeah.
So you're a pretty intense guy.
I haven't been named that yet, but that's about the triathlons are fun. Being a former swimmer and such, it's kind of my way to kind of stay do a little competition and keep my fitness up too.
It's good. It does give us a good insight into the patients we take care of too. We're asking questions about these things. It's nice to be able to say, hey, yeah, I do this too.
Exactly.
And you're married. You've got 3 kids. Tell me about the family.
Oh boy. So we got a 12-year-old, a 9-year-old, and then to keep it interesting, a 2-year-old. So it's quite busy at our house.
You get a couple of free babysitters there then?
Yeah. Well, yeah. We're one's in training and she's doing a heck of a job. So yeah, it's great. Excellent. It's good stuff. Yeah.
Excellent. Well, Eric, thanks again. Thanks for coming. And just wanted to talk a little bit of another common postural abnormality that we see, ankle distortion syndrome. Let's talk a little bit about that and tell me what you look for, what you see, or what you think of when you hear that term.
Yeah, ankle distortion. So ankle distortion syndrome, what I think of is I go down at the foot and I'm thinking of what we call an overpronation. So pronation is, think of a foot that is flattening out, losing its arch and rolling inward, if you will. The importance of this, or where this can become an issue, is that it doesn't. Not only does it affect the tissues and the mechanics at the foot,
right,
but it can affect everything up the chain. When I say chain, meaning the knee, the hips, and then the hips are intimately attached to the spine, so even issues up there. So it's not just a foot issue. It can be an entire body.
Right, and one of the things we've been saying through this 3-part series is that these postural issues, they're not just aesthetic issues. Right?
Yeah.
That one little thing in that kinetic chain that you talked about can run its way all the way up, to the knees, to the hips, to the spine, and cause problems.
Cause issues, overuse problems in the tendons and the muscles, and then even kind of if your mechanics are off, make the joints work overtime, and you can start getting some wearing issues there as well.
Is this a common issue that you see, posturally speaking, or
at the foot? And anecdotally, from my experience, I being down here in the South, it's hot a lot of majority of the year, so people tend to wear more, flip-flops and such, shoes without support.
Right.
And what I saw in the clinic, when I was prior to starting my business, was teenagers, especially females, girls going into puberty when their bodies are changing, and they have these issues down at the feet, can really wreak havoc on their knees. And your folks are like, well, what happened? I didn't have an injury or such.
Right.
Like, well, so I think a lot of it, the feet can really, by, poor choice of shoe wear or having, lack of support down there,
arch
support can really cause some issues. Now, I'm not saying that we have to wear shoes all the darn time, but if you have a propensity, if your genetics do play a role here, if your parents had really flat feet and you have flat feet, and you're not doing exercises that would engage those muscles down in the foot, those postural muscles, if you will, in the foot,
right?
Yeah, you can set yourself up for some issues.
Okay, and then you mentioned genetics a little bit, right? If your parents have it or one of your parents have it, you may have that flat arch you're talking about, which causes your feet to collapse towards the midline, the center of your body, and that cause that pronation issue.
Right.
Any other one that you think about that's likely to suffer from this, either through lifestyle or genetics even?
Yeah, folks, when I'll take a step back. Remember, I was talking about teens going through puberty and such, as the pelvis starts to broaden with females, the angles of where the legs meet, the leg bone meeting down at the knee, that ankle can change, and you can start developing some kneecap pain and such. Maybe folks who are hypermobile, just in general. Hypermobile meaning maybe really lax. That person who can straighten their elbows out and it looks like it's a reverse curve. Someone who can pull their finger back.
Kind of a hyperelasticity type.
Exactly.
Joint issues.
You can see that. Where it becomes a problem, though, is as we've mentioned, how when that foot hits and collapses, it really does make a change at the knee and as well up at the hip and such, and that's where we can start getting ourselves in trouble if we're doing a repetitive activity.
And what are the typical symptoms that you see? Obviously, they have the flat arch and knee pain, hip pain. What are the common types of symptoms that you see? Yeah.
So from an observation point of view, literally what I see is when I have someone come in, let's say with a foot issue or maybe a knee or hip, first thing I'm going to do is put them in a one-legged stance to see how well they can balance. That tells me a ton. And then from there, I can kind of see who's not doing their job.
And when you say not doing their job, let's say you put them in that one-legged stance and they have this, ankle distortion. What happens to them when they're in that stance?
Yeah. So let's say that foot collapses in as we predict.
Right.
What we're going to see then is the knee kind of rotate, rotating inward, and the thigh kind of coming towards midline, what we call adduction. Okay, so it's almost a rolling in of the upper and lower leg, as that we call it the term valgus collapse, if you will.
And valgus is pretty much the inward pointing of the knees.
Like knee knocked. Someone a knee knocked
knees, exactly.
would have a valgus.
Valgus, exactly.
Yeah. So, so that's that first thing I'll be looking at. Like, how well can they stand? Right. Not only does that tell me what tissue, what joints aren't working, but also gives me a little idea on maybe the supporting muscles. So we can go up the chain to the hips, to the big muscles, the glute max, and its job is to kind of de-rotate, if you will, kind of rotate outward and keep the pelvis level.
External
and the
rotation.
knees. Yeah. So kind of it helps combat a strong glutes help combat that falling in or that valgus collapse. So going back.
Kind of like what we were talking about with lower cross syndrome.
Exactly.
Having weak glutes and having that big curve in your lumbar spine. And so do you tend to see those occur together much, the lower cross syndrome and the pronation distortion syndrome or ankle distortion syndrome?
I mean, it's hard to say, but they do kind of follow each other, because I do see a lot of folks, when I'm someone who comes in with low back pain, who I'm treating, of course, in my observation, I'm looking at their feet too. What else could be causing, this back pain, especially if there's some asymmetries at the hip, that I'm looking down the chain to kind of see. So,
and any specific. So let's say they're in that one-legged stance. They kind of roll everything inward and collapse inward. What are some of the things that you'd want to do with them beside trying to strengthen their glute max?
Well, I would also, in an evaluation, what I'd also be looking at are looking at the joints, making sure the joints are moving appropriately. Are they moving too much? Or are they not enough? Are some not participating enough? Sometimes the hip is notorious for being too stiff and causing that inappropriate movement inward. And when it's not moving well, it also has a tendency to turn off the supporting cast that we already talked about, the important glutes.
Gluteus maximus.
So I'm looking at joints. I'm looking at the muscles that connect to the affected joints, the bigger muscles. Is their flexibility appropriate? Is it too tight? Is it too lax? So those are things too.
And when you see something like that and you know that their arches are collapsed, and that's at least part of the problem here in rolling them inward, do you recommend that they see maybe a podiatrist or get arch supports or anything that will help support that arch?
That's a great question. Yeah. So I will. My first thought is to see if can we correct this by just doing strengthening exercises and such. If the collapse is so great, then I'll suggest potentially going to the podiatrist and such, and going for that kind of that rigid orthotics. Technology has allowed us now that folks are corporations are making some really nice off the shelf orthotics, and I typically start there. It's a little, to be honest, it's easier on folks' pocketbook. Right. And there's some decent ones that you can purchase off the shelf for a fraction of kind of the cost of the orthotic.
Do you have them do that as part of your regimen, or is it maybe a case by case basis?
I'd say case by case, kind of looking at their activity level, their how compliant they're going to be with some of the exercises. I mean, truthfully, I'm looking at a lot of different things.
Because this is kind of like, it's going to help, but it's not really going to treat the underlying issue. It's just going to support them while you're
give them some
trying
support,
to correct them.
to correct the mechanics. Yeah, so it's more of a...
Kind of like those postural braces for upper cross syndrome to pull your shoulders back.
Oh, those
that doesn't really...
Yeah, those make me gag a little bit. It's a... Yes, I won't totally put them to that side, but it's a nice corrective measure to kind of maybe like a shim in a house, kind of bring things a little more level.
Avoid that rolling inward.
Yeah. And then give us a nice base to strengthen off of.
Got it.
Yeah.
Makes sense. And then, so when they have this ankle distortion syndrome or pronation distortion, what type of injuries do you find that they're susceptible to now?
Sure. Yeah. So starting down on the foot, we think of plantar fasciitis. That's I mean, you can ask, someone on the sidewalk, and about 9 out of 10 people say, I've had it, and it's not fun. So that's a kind of a repetitive stress injury to the fibrous tissue on the bottom of the foot. Moving up a little bit is the heel cord, the Achilles, Achilles tendonitis can develop from that, again, from those poor mechanics that falling through. Think of these as repetitive stress injuries. Moving up the chain up to the knee, kneecap issues, or what we call a patellofemoral syndrome, if you will, that, folks who are have that pain that just feels like it's underneath the kneecap, pain after you've been sitting a while and you stand up, it's that kind of ache, that pain that when you do like a little squat, you feel it kind of just a sudden jerk, those. And then even in someone in an athlete, let's talk about if they have this tendency to fall in there, and they don't have the strength up the chain, ACL tears, because that position that we talked about, that rolling in, makes someone very susceptible to tearing ligaments, and that's a pretty big deal.
In the knee.
Right? Yeah. Sorry. Yeah.
And when you say up the chain, tell us about the kinetic chain, just so our audience understand what they mean, what we mean when we say that.
So I'm thinking think of it, the body as kind of a linkage of different joints here. So we're down on that foot, we've got starting at the ankle, which is then linked to the knee, and then literally linked up to the hip. I like to link the hip to the spine, and you could go all the way up to the head, to be quite honest.
Right.
Yeah,
this is the kinetic chain, where we keep using this term because if you affect one piece of it, it's all linked. So it's not going to happen in a vacuum in an isolated fashion. It's going to affect the other pieces.
And as we've mentioned in our other podcasts, the path of least resistance, the body is so smart. If it senses any weakness up the chain, it's going to say, let's let the forces kind of go through there. And that's where folks can get themselves in trouble for those, repetitive stress injuries and such.
Right. And any particular exercises in the gym that you would say, well, maybe you might want to avoid that or drop your weights if you have this pronation distortion, ankle distortion?
Great question. Yeah. My first thought would be anyone who's doing squats and such. Before you start really increasing the weight, go in front of a mirror and do, and do a squat, and make sure that you can do it without your knees kind of coming together as if they're kind of, going to touch. You need to be able to do a squat and use an appropriate weight where your legs are square in front of you. The kneecaps are aligned with maybe the second and third toe, not deviating inward, because that's where you're going to get in trouble. So I think being really specific with your technique, aware of your body, body awareness with exercise will really keep you healthy.
Yeah, and this is why just an assessment with your physician, with your physical therapist, we want to make sure, even your personal trainer, you just want to make sure that somebody is looking at this alignment before you start loading that barbell up with a lot of weight. And then now that weight's going to be taken in your knees or in your hips and in places where you don't want it. Yeah. And when you're doing that squat, where are you pushing through in your feet when you're getting up from being down low to up high? How should they visualize or concentrate on where that force goes?
Yeah. So there's the tendency is for folks to be more quad dominant. My bias, and as we talked about, remember how important the glutes are, is to let the glutes be the primary mover of a squat. To do that, to really bias the hips, what one has to do is to think about when you squat to really push the hips backwards, as if you're sitting into a chair. Or going down to the commode. That's what we want to see. We don't want the knees passing the toes. We don't want the kneecaps going past the toes. We want the hips to be doing more of it. And you're going to notice as you do that, your weight's going to shift back onto your heels as you press up, and you'll notice as you push to stand, you'll notice the glutes engaging. And I think
that's a great point there, the key, where the force has got to go through your heels. And another way to do it, you imagine it's like sitting in a chair. Try just sitting in a chair, and getting up from a chair and get used to that movement. You'll be surprised.
If this is something you deal with, if you just get rid of the weights and just start working with body weight, you will get a workout. Don't be confused. Yeah, if you really start honing in on your technique, you can get a great workout.
And once you understand that link, that myoneural connection of what you're supposed to flex, how you're supposed to move with using body weight or no weights, when you do use weights, you're going to be more likely to engage the right musculature.
Right. Yeah. You're going to be more efficient mover, if you will, or machine. And I think you'll notice the ability to do it, number one, more comfortably, but also and be able to have more power. You'll feel stronger when you're doing the exercise. So,
excellent.
Yeah.
And speaking of power, Eric has started a company called Move and Power, Concierge PT. And if you're interested in him coming to take care of you or you have any questions for him. Consultation.
Free consultations,
Great. Yeah, that's great. And if you're interested in doing that, please visit the link in the show notes. And I'd like to thank Founding Media for hosting us. And we'll see you next time, guys. Thanks so much for tuning in.
Thanks.